Everyone, myself Dr. Kalpesh Hansora. I'm intervention cardiologist at SAR Hospital, Ahmedabad. So here we are going to discuss about the my best intervention case. As all intervention cardiologists doing the interventions and at one time difficult team challenging case, we always face the situations. So here we'll discuss about the which was the case which I have done a few months back. He was a young boy, 34 years male, and he has presented with the chest pain on exertion since 15 days on and off. We took the ECG. There was no significant STT changes in ECG, and he is having a sinus rhythm. But he had a strong family history of CAD. His father and elder brother had a coronary artery disease, and he has died because of CAD. We performed the echo, which was ejection fraction was 60%. There was no RW of LV. Cholesterol was 140 and LDL was 95. So there was no dyslipidemia and lipid profile. He did the homocysteine, which was more than 50. So he's been diagnosed as a hyperhomocystinemia. We took him for CAG because of the classical angina pain and exertional chest pain. And then we have planned for coronary angiography as he had a significant history of the family history of CAD. The LMCA lesion was normal, LAD lesion was eccentric 80 to 95%, and there was a ostial 80% lesion in diagonal. The rest of the vessels was normal. Here the angiography picture you can see. In first sonography, there was a tight 85 to 90% eccentric, which was very fibrotic in nature, significant lesion in LAD. And in diagonal, it was small to medium sized vessels. There was ostium involvement of diagonal vessel, which was 80%. So we thought about this is a case of simple angioplasty because the diagonal is originally so far from the lesion. So we have not planned for the bifurcations considered as a bifurcation lesion. So we took him for the PTCA stent to LAD and balloon dilatation to the diagonal. If needs, we'll do the provisional stenting. This was the pre-Ivaston we did. There was showing significant narrowing of the coronary blood vessel LAD lesion, and there is the eccentric plaque in mid part of LAD, which was fibrotic in nature. So we have decided to do first PTCA wiring with the filter FC using Walcos wire. We did the wiring and we pre-dilated with 2.5 15 millimeter NC track balloon. As we were knowing that it was fibrotic in nature, so we did the we had go ahead with the more aggressive dilatations to match the exactly size of the vessels and pre-dilatation balloon. But after that, we have noticed that patients had a chest pain after dilating the mean LAD lesion. When we checked, there was significant narrowing of there was a plaque shift in diagonal vessels. So patient had a chest pain on table and there is small fall on blood pressure and there was a significant changes in ECG. So what we have done, we have wired the diagonal vessels also and we have dilated with 1.5 with a 10 millimeter of semi-compliant balloon and we re-established the flow in diagonal vessels. Here you can see there was a dissection in mid LAD lesion. So it's showing that still the plaque has not that much modified with even NC balloon. So again, we took another NC track balloon. This was the 3.5 15 millimeter NC track balloon. We have tried to dilate as maximum pressure 22 atmosphere, but the waste was not disappearing. So there was tight fibrotic lesion. And as you know, that if you leave this kind of vessel and if you put a stent, there is a high chances of the stent thrombosis as well as the in-stent restenosis in future, and stent remains underexpanded. So there was a dissection, and there was the lesion was not modified and not bagged with the NC track balloon. So what is next? So we thought of doing rotablation, but patient had already had a dissection in mid LAD. The rotablation was not available at that time. So second, we thought of the IVL balloon, but the patients having some financial concerns, we cannot use the IVL balloon. Then we took the OPN balloon, as we know that it is the high pressure balloon. Commonly, we use the OPN balloon in a post PTCA after stenting for the post dilatation to expand the stent. But in this case, because of the fibrotic nature of flag, we have used this 3.5 10 milliliter balloon, OPN balloon, to break this fibrotic region. We have dilated up to 30 millimeter of atmosphere, 30 millimeter atmosphere, but still we could not able to break the region. But same time, patient again had a chest pain, and he started having a fall in blood pressures, and there was some ECG changes. So when I checked the angio, there was a long dissection from mid LAD to the distal part of LAD. So I thought to put a stent directly into the LAD and then see what happens. So that time I could not able to save the cine angiography of that dissected part. So we directly took the stent that was 3.5 into 40 millimeter SR summit. So you can see here there is a nasty dissection in the mid part of the LAD, which was flow limiting. We deployed the stent at 14 atmosphere, that was 3.5 into 40 millimeter. After that, the patients stabilized as the flow is re-established. But we have noticed that the stent has not expanded at the tight mid LAD part where the region was tight. So again, we have decided to post dilate with the same OPN balloon which was available, which has been used with the pre-dilatation. So 3.5 into 10 millimeter dilated with 35 atmosphere. So again, repeatedly we have given almost 3 to 4 times dilatation up to 35 atmosphere, and we have went to up to 40 millimeter. But still there was some residual expansion, under expansion in mid LAD part we have noticed. So after this dilatation, we have asked for the IVUS run, because if there is under expansion, we can go more aggressively. So after that, we did the IVUS. So this is a before angiography, before IVUS run. This was the results post dilatations. There was some residual amount of the under expansion of stent at mid part, but overall flow was good. Expansion, diagonal flow was good, and diagonal lesion was not that much significant. Then we did the IVUS run. This is IVUS run, which was showing a good expanded stent at mid LAD, and there was the good apposition with the vessel wall. There was some amount of the under expansion in mid part. Here we can see. Otherwise, the stent was well apposed and well expanded throughout the vessel. So this was IVUS run. The stent was good. There was no residual dissection, and then this was the final shot we took. And so ultimately we did the PTC stenting, and we have pre-dilated with the OPN balloon pre and post. So take home message is always use IVUS imaging or OCT imaging to decide the morphology of plaque, so you can plan for the bed preparation before stenting. And OPN balloon, we know that it's high pressure balloon and it's unique technology, that twin layer technology used to break fibrotic lesion, and also useful for the post dilatation in under expanded stent to prevent the further mesh and the stent restenosis in future. Thank you.